Kerry.
Yes.
Why did the new parents go to the jazz club?
I don't know. Why, Dr. Scott?
I love the way you say that. But yes, because they were feeling the baby blues. All right.
This is STIRRUPS, Candid Conversations in Women's Health, the podcast where we answer your burning questions and discuss the evolution of women's health through every stage of life. Join Dr. Randolph Scott and duly certified women's health nurse practitioner and certified nurse midwife, Kerry Autry, as they discuss the unique health concerns women face and share expert advice to assist you on your journey to maintaining your health and wellness. If you're looking for informative discussions, tips from qualified professionals, and a community dedicated to women's well-being, then you're in the right place.
We're starting our next really talk and discussion. We want to talk about postpartum. The baby's here.
Baby's here.
What do we do?
We've spent like 9 months planning for that. And somebody hands you a baby and you're like, okay, now what?
Well, there's a lot that comes with that, right, Kerry? And
Absolutely.
so immediately the range of emotions are there for us. But now the baby's here, and how do you make that transition is what we really want to discuss. And that transition is not a day long. It's not 2 days long. Sometimes it's months on hand in order to kind of get back to feeling the way things were before for us. And so with that in mind for us, we're going to talk about, the initial events and what happens. And I'll let you get kick-started with that, Kerry. So,
I was going to say, I think you make a good point, though, because, people will always find out that they have an appointment. They're supposed to go back to their OBGYN. Some people miss that. But after you have a baby, you're supposed to go back. And we've put this arbitrary date on the calendar, like 6 weeks.
Yeah.
So you come in for your 6-week postpartum visit, and everybody thinks that you should be like back to yourself and bounce back to yourself. Life should be exactly the way it was before, except there's like a cute little bundle somewhere in the house.
Right.
And it's just not true. Not everybody feels great by 6 weeks. Not everybody feels like themselves by 6 weeks. It takes, we tell people all the time, it took you 9 months to get here, 10 months to get here. It can take you 9 months to 10 months on the other side to get back to feeling like yourself.
That is very fair. And I had a patient say to me one time, who came up with 6 weeks?
I wonder that all the time. Like,
And
who
she
put that
said-
date on the calendar?
She said, it must have been a man. I said, I feel offended about that. But yes, sometimes it's longer than anticipated. And the adjustments along the way are certainly important to try to meet at least some deadlines.
Yes.
And I think even what I have noticed in my career is that jobs have become more understanding in the sense that maybe 6 weeks is not enough.
Right.
And perhaps more time is needed to recover from the experience. And so initially, yes, 6 weeks. So immediately
you leave the hospital with a baby and you come home, and we don't spend a lot of time preparing people for what that is like when you go home, what to expect in terms of your physical symptoms, in terms of your exhaustion, like all the things that kind of come with bringing that baby home. So we wanted to spend a little bit of time kind of breaking down reasonable expectations so that you know what to expect when you leave the hospital. So I think the first thing that we wanted to talk about was bleeding. You will start bleeding after you have a baby. It's been a long time since you've had a period, but you will have period-like bleeding for usually about 2 weeks after you deliver the baby. And it'll change in color, it'll change in intensity, but it should get to be less and less over those 2 weeks.
Yeah, I think the taper is what's important. But also to temper expectations, what that taper means. Some days might be a little bit heavier than others. But from 1 week to the next, certainly you should notice that things are getting a little bit lighter. For some patients, they may bleed right until the day before the appointment.
It's right.
And that's not unusual, again, as long as it's relatively small or light, and it seems to be getting better and better as the healing process is taking place. And really as the uterus is getting back down to its normal size from pregnancy to post-delivery phase. And it takes weeks for that to happen.
And sometimes that bleeding can kind of be a good gauge of maybe you're overdoing it. If the bleeding is getting to be less and less and less, then one day all of a sudden it picks up and you think, wow, what happened? And you're looking back into your day and you're like, well, I organized the fridge and I cleaned the bathroom and I did 3 loads of laundry. Wonder what it did. Wonder what happened. Bleeding can be a sign if it picks up that maybe you're trying to do too much. You really need to give your body some time to recover from pregnancy and from labor.
Sure.
So aside from bleeding, there's also going to be some pretty big changes with your breasts. After you deliver a baby, your breasts are going to be ready to make breast milk. For the first couple of days, that's going to be colostrum, which does not look like milk. So that can also surprise people. It is thin, it's yellowish, and that's what it's supposed to be. About day 2 to 3, it will start to change to breast milk. If you don't plan to breastfeed, then you want to make sure that you're wearing a really tight bra all the time. Try to avoid any stimulation of your breast because that's just going to cause your breast to make more milk. If you are breastfeeding, then it's really important that you stay with your baby as much as possible, feed on demand at least as much as you can for the first couple of weeks to help get that supply established. And try not to put too much pressure on yourself. The supply will be established usually at about the 4-week mark. So by the time you get there, you're pretty good. But as long as that baby is making enough diapers every day, try and take it in a relaxed way.
I think patients are trying to figure out, is my baby getting enough nutrition?
Yeah.
And you just, hit the nail on the head. How
Absolutely.
do I know that?
Yeah.
And the way that you know that is how many diapers are you going through? How much weight is the baby gaining? That can give you some knowledge about where things are going.
And that's true with breastfeeding or bottle feeding. The other thing that I think parents are often surprised by is that breastfed babies can actually go a couple of days without pooping, and that's okay. Yeah. As long as you're getting 6 to 8 to 10 wet diapers a day. And as long as the pediatrician is happy, baby's meeting the milestones, baby's growing, then you're doing everything you need to.
All right, Kerry, this is going to be the toughest question all day.
Ooh.
How do you make it stop? How do you draw up the milk?
Oh, when it's time?
Yeah, when it's time. Now,
whenever it's time, yeah.
Now
whether
it's day 1 and you're like, this is just not working for me, or if it's a year later.
Right.
That is usually a common question that we get about how do you quit that process so that it's not as challenging. So...
Well, it looks a little bit different depending on where you are. If you've decided that you're not going to breastfeed at all, then like I said, you wear that tight bra, avoid stimulation of the breasts. And I mean really any sort of stimulation, especially heat. So even in the shower, you want to kind of keep your back to the shower and only let the hot water hit your back. You can put ice packs in your bra. That can really help bring it down. Ibuprofen is going to be really important. It will help dry up the milk, but also help manage any of the pain that you have.
Yeah.
Now, if you've established breastfeeding and you're trying to wean a baby, that works just a little bit differently. For your comfort, you want to actually just start to limit the number of feedings per day. Maybe you drop 1 feeding, if you're going to be choosing. If it were me, I'd definitely be choosing that like 4 a.m. feeding and let dad take over the 4 a.m. feeding with a bottle. But you want to start by dropping 1 feeding at a time so that your breasts have time to adjust. And then as you get towards the end, it'd be the same thing, really tight bra, avoid stimulation, ice, and ibuprofen.
Cabbage leaves.
It works. It works.
Yeah, that's a great one.
It is.
It does. It works.
Yeah.
So that might be part of the process. But yeah, so obviously we want patients to be able to continue as long as they find it feasible for them to do so, but also the means and mechanisms to perhaps slow things down when ready. Nursing can be challenging, whether the baby is strictly breastfed or if the baby is actually taking a bottle, whether that's formula or taking a bottle through the breast milk that has been stored. It's not an easy process, but pumping obviously is a mechanism of which helps mom to integrate them back into perhaps going back to work and some things like that, and still be able to give the baby the nutrients through the breast milk. But the challenge of the pumping is, it's one that I think is understated in a lot of ways, is because it's just not the aspect of pumping, but as soon as you're finished pumping, then you got to clean. Then you got to clean all the supplies. Yeah. And by the time you finish cleaning the supplies and the and the bottle's dry, the baby's ready to be fed again. So not to be discouraging. Obviously, it's for a fantastic purpose in terms of being able to deliver the baby nutrients in ways that they say breast is best for a reason. I think it surpasses formula, although formula is a great mechanism in terms of being able to get the baby what it needs. The whole aspect of pumping can be challenging. And, from a patient standpoint, the biggest deal is trying to perhaps getting the milk supply. And so, in the very beginning stages, when you pump, do you get a whole lot of return?
No, I pumping is hard, and I tell patients all the time, it's a tough way to go, but there's a lot of good reasons to do it. I think we do moms a disservice all the time. I mean, we hand them this baby, and the impression that we give patients all the time is like, well, you had a baby and you have breasts, so here you go. Like, this should all just work. And it's not always that easy. Sometimes babies have a tongue tie, or sometimes there's a cleft palate. Sometimes there's something about the baby that makes that latch just not possible. Sometimes there's something about your nipples that's a different shape that can make that latch really, really difficult. And anyone who's tried to breastfeed a baby will tell you that, like, as those things happen and as you have difficulty latching, the stress level goes up. And as the stress level goes up, that baby is going to feel it. And then everybody's crying.
And everybody's feeling it, right?
Mom's crying, baby's
Dad
crying.
is in the back crying.
Right. So a pump can really kind of step in and make a big difference for you. But you're absolutely right, Dr. Scott. When you if you're starting in the hospital and you're starting with that pump, it's really important that you get the measurement on the pump pieces correctly. Not many people know that the flanges on pumps come in a number of different sizes. And the sizing makes absolutely no sense because they have you measure your areola and you come up with a millimeter width of your areola, but that doesn't actually correspond to the flange size. A 17 millimeter areola, I think, is actually like a number 20 flange. It doesn't make a lot of sense. So it's something to either get done in the hospital or go to see your provider as soon as you can so that you can get measured and get the right flange size, because that's going to cut down on your frustration tremendously to get that right flange size. And then when you attach the pump, paying attention to make sure that you have the right flange size, you can actually watch the way that your breast looks inside the pump to tell this is really the correct, this is the correct fit for me. You should, feel that pressure from the pump, but it shouldn't be extraordinarily painful. You'll actually see your areola like move into the smaller part of the pump flange. And that's a good sign that you've got it in the right place and that you've got the right size. Because at first, you're only going to get drops to maybe milliliters to ounces, but all that takes time.
Right.
And the key when you're building up your supply is that when you put that pump on and you pump until there's nothing left, leave the pump on for a good 5 minutes on each side, because that's telling your brain we need more milk. We're not making enough yet. And you just keep doing that or adding in pumping sessions in between. And that's how you can get your supply up. But it can take a little while. And I think the other thing that I run into with patients all the time is when they come in and they're saying that they have supply issues, either the baby's not getting enough or they're not getting anything out of the pump. My first question is always, have you eaten anything? Yeah. How many calories are you getting in? How many fluids are you getting in? Because you have to put in enough in order to be able to make that breast milk. And for new moms who are not getting any sleep and are running around after toddlers or taking care of babies or all of the above, very often that's the biggest problem, is that they're just not eating enough.
Yeah, not getting enough in terms of liquid intake. I mean, I truly believe what goes in comes out. And so it's important to stay hydrated during the process. And so back to our moms who did not have a vaginal delivery. Our goal always is to have really a healthy mom, healthy baby. Sometimes, there's a great bit of disappointment not having a vaginal delivery. But at the end of the day, if we have a healthy mom, healthy baby, those are the outcomes that we're looking for. And in terms of incision, there's a couple of ways in terms of incisions and the way the incisions are closed. For most providers, they're probably dealing with either an incision that's closed by suture. That's kind of like needle and thread, just kind of put together, holding things together until your body forms its own sealants. Or the second way that the incision is closed is through staples. Now, as strange as that sounds,
mad when you even say that. Nobody wants to hear that.
No, nobody wants the staples. Everybody's in fear of the staples coming out. But technology is a great and fantastic thing. It has moved to the point that when I first started, when we were placing staples, they were metal staples, and you had a little staple remover, and it made these awful noises, and then sometimes the staples wouldn't come out perfectly, and then they get caught, and then the patient is like, "Oh my goodness!" So I understand why the rep on the staples.
They have a bit of a history.
Yeah, it's good. But now there are actually absorbable staples, and a lot of providers are using absorbable staples in order to close the skin incisions.
In surgery time, I'm not a surgeon, so I'm guessing that it actually cuts down on the amount of time that a patient is in surgery to be able to use that.
Oh, the absorbable
stitching
staple
can be lengthy in terms of the amount of time it takes.
Oh, the stitching is one of which you obviously it requires a lot of skill and precision to it, and because of that precision that you need, it can take longer, and that's more time in the operating room and so forth for you. So the staples are becoming much more popular in that regard. Now, caring for the incisions are very similar because if you have the absorbable staples, there's nothing for you to take out. Your body will reabsorb the staples without any issue or concern. But the care for it is important for you, no matter whether it's a suture or whether it's a staple for you. You want to try to keep that incision as clean as possible. And you want to try to keep that incision as dry as possible. Now, sometimes the overhang that you have, where you're still dealing with a really big uterus and your belly is kind of tucking the incision in, that sometimes can be a challenge in terms of keeping it dry. So oftentimes I'll have patients just put a cloth or a rag right under the incision to keep it dry, because moisture can breed the aspect of infection for you. So if you can keep it dry by whatever mechanism, that's actually a great thing.
I like to have them stick a menstrual pad to the inside of their underwear, like just under the waistband. If you just stick it right to the underwear, it'll keep it right against.
Oh, that's a great idea. And it has some adhesive to it, so it doesn't move or anything like that. And so it provides some dryness.
And pulls that moisture away from the skin.
That's right. And certainly with the closure, you can shower, you can bathe. It doesn't matter.
In fact, that first shower will be the best shower you've ever had.
So I've been told, yes, that is.
I was going to say, you'll have to take my word for it, but it's the best shower you've ever had.
So you can certainly get it wet. There's no problems to getting it wet. I think some patients have some fear about getting the incision wet. Maybe it's going to break down or something like that. From any C-section, I have never seen anybody bust open their incision from doing normal activities. So certainly normal activities, I think, would be appropriate. And so incision-wise, clean and dry, that's the simple message in regards to incision.
Can you talk a little bit about, I find a lot of times when I see a patient for their 2-week check, I'll say something like, have you looked at it? And they're all like, oh, no. Like they have no idea. Nobody has any idea what to expect for it to look like. And what it looks like at 2 weeks and what it's going to look like at 6 months are very, very different things. So, I always walk them through. Let's look at this together. Let me tell you what I see. This is all healthy. This will change. This is not you forever.
Yes. And so that's actually a great thing to really comment on, because the earlier you get to a problem, the better off it is in terms of treatment and management for it. The number one thing that we worry about is obviously infection, incisional infections. That's a huge thing post-delivery. And how do you recognize that as a problem for you?
Right.
And so number one, you got to look at the incision.
You do.
You do. And so now when you come home, they got you all taped up and, all bandaged up and from a C-section. But, they have what's called STIRRUPS, which is the taping that you apply to the area that's supposed to be on. For most providers, they'll keep that on for approximately 1 week post-delivery. But by day 5 or 6, it looks a little scraggly, it's hanging off and all of that good stuff.
There's a lot of swelling.
So,
there can be a significant amount of bruising.
and
That's
moisture.
Also,
Yes, that's a factor too. But the hallmark to anything problematic is the level of discharge that you can have. The secondary factor that we also look at is if there's expanding redness. And so that means that, hey, this area of redness is a little bit bigger than what I was anticipating. Yes. You'll also notice the bruising that takes place. Now, the bruising is generally not much of an issue because, again, you had to place suture and things under there. So I don't ever want patients to worry about bruising. That's not a major issue. However, symmetry is important, meaning that the left side should look like the right side. Okay, if you got a mound on one end and it's flat on the other, then certainly that's a challenge. And the theme of any incision is, if you don't know, most providers are happy to take a look.
In fact, we would rather.
Exactly. Yeah, and try to meet you at a time where we can intervene before anything major takes place.
I tell people all the time, I'm like, come on in. I would so much rather look at it, tell you everything is fine, and then have you sleep well that night.
Yeah.
So if you're worried about something, just ask.
Yeah. I think that's a take-home point there.
Yeah.
All right, what can happen post-delivery? Post-delivery, changes are taking place. We got incisions all over the place. There's one that I think is overlooked for us, and I think oftentimes hemorrhoids become a factor. Now, hemorrhoids can often be problematic well before that baby comes out, and so there's a variety of ways to really manage them. But you can be more aggressive post-delivery. And so, in terms of hemorrhoids, how have you seen it impact patients?
Well, I think it's, like you said, they can come up during pregnancy too. So for some patients, postpartum, it's not a new thing, but they can often be worse postpartum. During pregnancy, you have the constipation, which just goes with pregnancy, which is going to continue postpartum because your body has just been through a heck of a lot. But then you've also had whatever amount of time you spent pushing, and the pushing can actually, if you didn't have hemorrhoids before, it can certainly create them or exacerbate the hemorrhoids that you had before.
Yeah.
So it's really common to have them. And I think it also really adds to the anxiousness that people have about that first bowel movement, which can take a while, again, because of just the trauma to the abdomen, whether you had a C-section or a vaginal delivery. A lot happened here. So it takes everything a while to come back. So the most important part of managing hemorrhoids is managing the constipation.
Yeah.
So it's really important when you are in the hospital, they are probably going to start you on Colace. Ask them to give you some and take it home. Take the Colace every day, probably for a month. It's not going to hurt.
And as a matter of fact, Kerry, for some of our patients that, I'm anticipating that there's going to be a challenge in that meaning that,
we're already seeing it month 8.
Right. There's been a struggle already.
Exactly.
We know we got to do something. We got to help you out before the day comes. I'm often recommending stool softener or Colace
absolutely
before delivery purposes. So let's get that done. And if you're not having regular bowel habits, I think that's a very good idea, particularly as you're getting ready to go into the phase of anticipating delivery. And so the stool softener Colace, I think, is great to really.
It's a great tool for the anxiety too, right? For anybody who had a vaginal delivery and had any stitches. The first thing they're going to tell you is that they're terrified of their first bowel movement. So getting that stool softener on board, even before delivery, can be a good thing that you have a little bit more confidence that that's going to be less stressful than it might have been otherwise. Yeah. So managing the constipation is, keep that stool softener, a little bit of fiber in your diet. So some good leafy green vegetables, walking. I mean, I don't want you to walk 12 miles, but I do want you up and moving. And then for any hemorrhoids that are there, of course, the Tux pads, which are fantastic after delivery, no matter what. The Tux pads that you can add, and then a little bit, you can even use like a Preparation H, which is just a steroid that you apply.
Yeah. And depending on the severity, sometimes you can go further than that, but usually most providers are hesitant to at least not consider anything that is surgical or anything like that, because typically hemorrhoids do get better as the postpartum period continues for you. So,
Agreed.
So, obviously it's an option, but it's one that's usually held back in terms of seeking more attention outside of some of the things that you mentioned.
Definitely the colace walking and good fiber is going to be easier than a procedure. Right. So if we can get you out of that procedure,
yeah, that's the way to go.
It's definitely the way to go.
All right. The next challenge in the same areas, really peeing, or how does that take place? Sometimes when you have a vaginal delivery, there's tearing that takes place, and because of the proximity to the urethra or where the urine exits, it could be in the same place, and some providers are placing stitches and suture around the urethra where the urine exits. And that could certainly be a challenge in a lot of ways. Number one, the stream. Okay. So, if you're expecting your flow to be directional, it's not. It may be all over the place. And that's okay. I promise you, for the most part, it does straighten out with some time.
Yeah.
But you're just like, oh my goodness, what happened? I can't.
Nobody told me.
I'm sprained.
I feel like people say that throughout pregnancy all the time. Nobody told me. Nobody told me.
Right.
Well, we're telling you now.
Right. So that could be a factor in terms of just overall flow. Again, we had mentioned the part of being hydrated. Still want you to kind of consume enough to be able to avoid in certain aspects, but it can be very challenging because sometimes it is just painful to do.
And that's the other thing. The more water, right. But if you water, the closer that urine is to water, the less it's going to be uncomfortable. And that Peri bottle is going to be your best friend. You fill it up at the hospital, make sure it's room temperature. If it's cold water, it's going to be really shocking. But you fill up that Peri bottle, start squirting that before the urine comes out, and just kind of continue throughout urination. And it will really help with the burning. It will also help keep any sutures clean to help with the healing process. But take that home from the hospital. Yeah,
the water bottle is a fantastic trick to kind of, like you say, keep things clean at the same time. For some of my patients, it can be really, really bad. And there's even lidocaine, a topical anesthetic that you can use. And we'll get more into that as we talk about overall vaginal health and care for us. But sometimes things are different, and it's okay that things are different. Things generally do self-correct themselves as time goes by, which leads me to the next topic, vaginal care. And so the same things that we were mentioning about, your difficulty of having to go pee or void, is some of it is, falls in line with vaginal care and the things that you can do. For most first-time moms, it's very, very rare. Did I say very enough? Okay. It's very rare to have a baby without any tearing. It can happen. So there's some things that perhaps you can do to help meet some of that challenge and minimize the tearing that you can have. But it's very, very rare that you would see a first-time mom not having any tearing. Now, subsequent deliveries, perhaps maybe that's more of a possibility. But first time around. And so vaginal care is very important. And you mentioned that Peri bottle. So that's, if you do nothing else, almost like a gun on your hip, have that Peri bottle, at times where you actually are going to the bathroom. And you mentioned the Tux pads, and there's one spray there that is a fan favorite. What's that? Kerry?
It is the Dermaplast. Yeah. Oh man. So when even if you don't tear, after pushing for any period of time, there's usually just a tremendous amount of swelling. So if you do look in the first couple of days or even the first week or two and things look completely different, it has to do with swelling. And the swelling will start to come down over time, and it will start to look more like it did before. It's never going to be exactly the same. You had a baby, but it will start to look more like it did before. So in those first couple of days with suture, without suture, again, water, water, water. It'll help with everything. Also, just most people don't know this, but be prepared after you deliver a baby. You are going to pee like you would not believe as your body just starts to shed all that extra fluid. And that's like 2 weeks where you're just, it's a remarkable amount of urine, but that's a good thing because that's how your body's getting rid of all of this extra fluid. So I tell patients, like, get the disposable underwear from the hospital. They're amazing. You'll wonder why we don't sell them all the time. Put that pad in that underwear, line up your Tux pads, 3 right along that large pad, and then take the dermoplast, put that right in the middle, and then somehow balance that as you pull it all up.
Look, you're talking technique. I
know. It's important.
Okay.
It's important.
I like it.
That sounds a little overwhelming the first time. You get the hang of it really quick.
Okay. Yeah, that's good. And to kind of, again, add to, what we call lacerations, and they can be in a varied degree of really complexity in terms of laceration. And we put them through 4 phases. There's a first degree, which is very minor. There's a second degree, which is kind of in the middle. And then third and fourth degrees become much more significant. And the laceration can often help determine how long the healing process is going to be for you at the same time. And so all of these measures, regardless of what the laceration is, can certainly be helpful to the patient. Now, the more difficult the laceration, the more stitching, the more swelling that takes place, the more time you have to give it to heal. Your expectations should change. I mean, if you have, for example, a 4th degree laceration, nobody is expecting you to have complete full recovery in 2 weeks.
No.
It's just not going to happen.
No.
But for some of my patients, when they go out and if they plan on nursing, or if they're not nursing, the pillow that you put around.
Oh, the boppy pillow.
Yes.
Yeah.
The boppy pillow. That is a fantastic resource if you have any tearing at all.
Yeah.
One for you, one for the baby.
Absolutely.
For you to sit in to minimize the pressure that you can have on the pelvic area as you're just going through your day-to-day and your normals.
The other thing, especially if you're talking a 3rd or 4th degree tear, please just make sure that your providers are aware. If your provider is not the same provider that did the stitching, make sure they're aware as you go in for that 2-week visit or that 6-week visit, because you're probably the patient that's going to need some pelvic floor PT in the long run to really help manage the scar tissue that's built up from that. Because again, 3rd degree, 4th degree, I don't care. At the end of the day, when you are fully healed, you should not have pain.
Yeah.
And that can take a little bit more. So this is a good opportunity for you to advocate for yourself or for your partner. If they're watching all that stitching, they're going to remember it. Yeah. They can advocate for you and say, you know what, I think she might need a little bit of pelvic floor PT to help recover and make sure that she really does get to a point where she has no pain.
Yeah, for our patients who are having 4th degree tears, I'm seeing the patient at least 3 or 4 times during their postpartum recovery period.
Absolutely.
Usually within a week, 2 weeks, just so make sure that things are healing appropriately.
Mm-hmm.
This was only part 1 of our in-depth discussion on postpartum care. Be sure to stay tuned for part 2, where we'll continue exploring more vital information about this important phase. Thank you for joining us on this episode of Stirrups. Be sure to send us your women's health questions and topics you'd like to cover by visiting our website, CarolinaEliteWomen.com. If you enjoyed today's episode, please subscribe to the podcast and spread the word by sharing it. To find out more information about Carolina Elite Women's Care, visit CarolinaEliteWomen.com. This podcast is edited and produced by Earfluence. Stay healthy and stay empowered. We'll talk to you soon on Stirrups.